So the YouTube link is now live. So we'll start having colleagues from our various organizations joining the call. We'll wait 2 minutes, literally 2 minutes, and then we can start. Thank you. Good morning, Florence. Shall we start? Florence, can you hear me?
Yes, we can start.
Perfect, perfect. So good morning, Florence. How are you?
I'm good, thank you, Marie. How are you?
I'm fine, thank you very much. It's a great pleasure for us to be here today and welcome such a high-level audience for a high dialogue on mental health and psychosocial support. Today, we are having a conversation with regional directors from protection organizations from the UN, ICRC, and NGOs. And I will kindly ask the regional directors to introduce themselves. May I ask Clémentine to introduce herself?
Okay, good morning. Good morning, everyone. My name is Clementine Unkweta Salami. I am the director for UNHCR's regional bureau that covers Eastern Africa, the Horn, and the Great Lakes region.
Thank you very much, Clémentine, and welcome to this session. Mohamed from Unicef.
Thank you, Marie. My name is Mohamed Fall. I'm the UNICEF Regional Director for Eastern and Southern Africa. Over to you.
Welcome, Mohamed. We have Michaela from IOM, who's representing the Regional Director. Good morning, Michaela.
Good morning, Mary. This is Michaela Martini, Regional Migration and Health Advisor Specialist for Eastern Horn of Africa, representing Mohamed Abdiker, Regional Director for Eastern Horn of Africa for IOM. He's bringing his regards to all of you, and he do apologize for his commitment. He could not join the last morning.
Thank you very much, Michaela. Patrick from ICRC.
Good morning, everyone. My name is Patrick Youssef. I'm the Regional Director for the International Committee of the Red Cross for the African continent. Back to you.
Good morning and welcome, Patrick. David Eastman from IMC.
Good morning, my name is Dave Eastman. I'm Senior Director for International Programs in East Africa, North Africa, Asia, and Europe.
Thank you, very pleased to have you on board. Patrick from REPSI.
Thanks, Marie. Good morning, everyone. My name is Patrick Onyango Mangen. and I work with the Regional Psychosocial Support Initiative as the Chief Executive Officer. REPSI is active in about 13 countries in the Eastern and Southern Africa region. Thank you.
Thank you very much. And Papa Ju from VSO, good morning.
Morning, Maria. Morning, all. So my name is Papa Diouf, currently based in Kigali. I work for the Voluntary Service Overseas, VSO, as a Global Practice Area Lead for Health. Thank you very much.
Thank you very much, and welcome, Papa, again. So welcome to colleagues from the various organizations who've joined us online today. You'll have the opportunity to ask questions to our regional director through the chat bar. And I'm kindly asking you to put yourself on mute if you're not speaking or asking any questions. I will now give the floor to Florence. Over to you, Florence.
Thank you, Marie. Welcome, everybody. A very special welcome to the panelists who could join us today. We have two sessions today. The first one is going to be on the impact of COVID-19 on mental health and psychosocial well-being of people across Eastern and Southern Africa. I'll first introduce myself. I'm Florence Baingana. I am the WHO Regional Advisor for Mental Health and Substance Abuse in the African region. This event today is the first of a series organized by the East and Southern Africa region, MHPSS Hub, which is one of the hubs in the Africa region. The Africa region, as you know, covers 47 countries, but this is only for a part of the countries that it covers. The event is organized as part of World Mental Health Day activities. Some of you may know about World Mental Health Day every year. 10th October, we celebrate mental health. This year's theme, there seem to be two themes. One was Move for Mental Health, Let's Invest. And the one that we are using today is Greater Investment. Greater investment, greater access. So as you can see, both of them are actually about increasing investments to mental health services in the Africa region. Just to say a little bit about the events that took place last week, I hope some of you were able to follow those events. We had on the 8th, on the 6th, was it the 6th or the 5th? There was the launch of the World Mental Health Day activities by the Director General, and the Mental Health and COVID Rapid Assessment Report was disseminated. This was the global one. And we may touch on the findings of that report if some of you have been able to read it, on the impact of COVID on the mental health and substance abuse services. The other event was on the 8th, where the Africa Regional Director also had a press briefing on that day, followed by a press statement. On Saturday, we had a big event. I hope some of you were able to join in the big event, which was aired from 5 p.m. here in the East Africa region, 5 p.m. onwards, 4 p.m. for the Central African region, and it went on for 2 hours. It was a very, I think, very educative, because it gave an overview of all the different services and interventions that we're able to provide, as well as the issues, the whole scope of mental health as far as the work that we do. So I hope some of you will take the time to go and look it up. The recording is there. So that's very, very briefly, just very briefly, the series of things that have gone on this year. For the first time, we have done everything virtually. Normally we would be meeting in Geneva. We couldn't do that. We actually had on the 8th as well, the AMH Gap Forum, which we normally hold in Geneva. But I will not go on with all that, because once I start, I don't stop. But let's move on to the first questions. So I'll hand over to you, Marie. Let's continue with this conversation. Over to you, Marie.
Thank you very much, Florence, and also very happy to have now 69 participants from different organizations. So that's very nice. Please ask your questions as we proceed. So, as you know, there was also that joint statement from the regional directors on MHPSS, which was launched on Saturday online. So also the first joint statement of that kind for this first ever East and Southern Africa regional event. Thank you again for the regional directors to come up with a joint statement on MHPSS in the region. And I will start with a question to my regional director, Mohamed Fall. Over the last year, we've seen how Unicef has increased its engagement on MHPSS from community-based interventions to global level. And we know that now MHPSS is part of the core commitments for children in humanitarian action. In ESAR, Unicef is also co-leading the WHO, the MHPSS group within WHO Case Management Technical Working Group, the forum which has contributed to the organization and launch.
I'm still trying to find out how to do about it.
Again, a kind request to put yourself on mute.
Yeah, you share the link with you.
So Mohamed, how has the pandemic affected children in Eastern and Southern Africa, and how has this affected their mental health and psychosocial well-being? Over to you, Mohamed. Thank you.
Thank you so much, Marie. Let me first greet you, greet Florence, and thank the working group for bringing us together. Let me also greet all my fellow colleagues from the regional office of different organizations, colleagues and partners. We are here together. I think this initiative could not be more timely. We know that we celebrate the Day of Mental Health. We celebrate the Week of Mental Health every year as a growing and as something which is extremely important. But I think there couldn't be a year where it's more timely and where it's a better place to talk about it. As you mentioned in the backdrop, you know, this year we are grappling with unprecedented crisis. I think it's a once in a generation crisis that we are seeing with this COVID-19 pandemic. I wouldn't talk about all the aspects and the ramification and implication of the COVID-19, but as you say, I just wanted to maybe focus it on the level of children. This has got a kind of major psychological impact on children. We say that this is unprecedented by its scope, by its nature, by its impact, but also by the number of people affected. In the onset of the crisis, if I want to just take one benchmark, which is children whose education was disrupted, we were talking about 140 million children in the 21 countries that we cover in Eastern and Southern Africa, whose education was disrupted. And we all know that having their education halted was not the biggest, the only issue that children were dealing with. They were dealing also with stress, with anxiety, linked to the impact of the diseases in their families, in their communities, among caregivers. And I think this itself has brought up the issue of mental health in the forefront in a way which is also unprecedented in recent history. And we have seen that the pandemic have impacted so much the communities in a way that also have got ramification in the socio-economic impact. And we know when parents lost their job, when parents cannot be productive, when parents have their income decline, all of these aspects also impact on the life of children. Thanks to a lot of partners' engagement into advocacy, into reminding to government the importance of reopening school and getting children back to school, we have seen the trends changing. Today, I can say that out of the 21 countries we have in the region, almost half have reopened fully, and the rest are reopening partially. And I think it's a good sign that children return to what I call normalcy. But let's not forget that also for those that have opened partially, they didn't offer all children the possibility to go back to school. We are seeing children's, for example, we're talking about 65 million children who still are having difficulties to connect because the platform or the infrastructure that is used for distance learning is not operating. And for me, this is not only a risk in terms of education, it's mostly a risk in terms of mental health, it's mostly a risk in terms of protection. We all know, we have seen previous pandemic, for example, in West Africa with Ebola, that when you have this long disruption of the school services, not only all children will come back during Ebola time in those 3 countries we talk about, up to 25% of children who have not returned to school. And if you look at the statistic and you disaggregate it, most of them are girls who are facing, in addition to the risk of dropping out forever, who are joining the large cohort of children who before the crisis were not attending school. But at the same time, we are further exposed to risks such as emotional abuse, physical abuse, even sexual abuse. Recently, we have seen in many countries a rise and a spike in the number of adolescent pregnancies, clearly showing the pressure that this lockdown will have in terms of impact, the pressure that this lockdown have in terms of further exposing children, mainly girls, to abuse. We do have also some other link with, for example, the mental health dimension. And unfortunately, most of those aspects that the children are grappling with in the context of the disruption of the school services are not things that are impacting on their life today, but they could have also a longer term impact into their life in general, and also putting a whole generation at risk of being lost because they would carry the impact they have in the psychological part, but they would carry also the loss of opportunity to finish or to complete education cycle. They will lose also an opportunity tomorrow to be the citizen that we want them to be. And I just maybe last word is that also what we have seen is that what we call in French the parent pauvre, which is the poor cousin in the family, is what mental health represents in the public health in general. We all know that public health in sub-Saharan Africa, we are struggling with investment, but the most sideline sector is the mental health. We have seen that less than 1% of the public health budget goes to mental health. And we all know that investing in mental health, as I say, could have a long-lasting return. And people say that in $1 invested, you can have up to $5 in terms of return. And not doing that one today is exposing, as I said earlier, society and the future of some of the African nations at stake because of the long-lasting effect that mental health can have on children. Maybe just one last word. You mentioned the corporate commitment. I just wanted to say that if we are talking about 140 million children in the continent, or in the countries that we are covering in Eastern and Southern Africa, let alone now the children who are already been in crisis before the pandemic. Children who are in a conflict, children who are displaced, children who are on the move, children who are in the refugees, and I'm sure my sister Clementine will talk about it. These also have a kind of further exacerbation of the challenge they were having, and now on top of it having COVID, on top of it having also disruption of the education system. Those are the challenges that I just wanted to share and to say how, for example, mental health, how the psychological impact of the COVID is now being a major threat for children in the region we are working on. Back to you.
Thank you very much, Mohammed. You have covered a lot of ground and a lot of issues, but all of them very pertinent. And indeed, going back to the Ebola, one of the impacts that we found during and post-Ebola was the pregnancies among young girls, and we are hearing the same thing even now. But one thing you touched on is the impact on refugee children who are affected by humanitarian crisis. I would now like to move on to Clementine of UNHCR. We know that Africa, the region, is one of those that has the biggest number of refugees globally, but also countries in the region are the ones that are providing the biggest amount of support to refugees with the support of UNHCR. We also know the conditions that the refugees live in. They already have psychosocial distress as a result of the conditions that cause them to become refugees. So they are already in a vulnerable position. And then on top of that, they live in conditions that are sometimes very difficult. It may be very difficult for them to have control over the amount of space that they have, to have control over social distancing, to have control over how much water they can have and how much hand washing they can do. So taking all these things into account, one would imagine that it must have been very difficult to manage the COVID and to limit the risks. So I'd like to just ask Clementine, some refugees have been living in camps for years, and UNHCR has always ensured that its interventions contribute to the mental health and well-being of refugees who have faced traumatic events. Support to populations in displacement is also at the core of UNHCR core activities. How have refugees been affected by the COVID-19 pandemic? And do you as UNHCR see an increased need for mental health and psychosocial support? You could also maybe also touch on a little bit if there have been any cases within the refugee camps or the populations you're supporting, and how have you responded to those? Thank you very much.
Thank you very much, Florence. Can you hear me?
Yes, we do hear you.
Okay, wonderful. Perhaps just to start by thanking really the organizers for this discussion, for really seizing this opportunity to shine a spotlight on an area that for many years perhaps has not received the amount of attention it deserves. I work in partnership with many of the people who are part of this panel. Unicef really collaborate very closely with us in terms of child protection issues, and Mohammed has spoken at length of the challenges confronted by children, only heightened in some cases by the fact that some of them are refugee children living in very, very difficult situations. Allow me to perhaps just focus on the plight of refugees, and in doing so, we also need to consider those who are forcibly displaced, including IDPs as well. In refugee situations, mental health problems are highly prevalent. Prior to the COVID-19 pandemic, I think WFO says about 22% of adults in conflict settings have mental health conditions. The region I cover has a total of 11 countries, and within these 11 countries, we have 4.5 million refugees and asylum seekers and 8.1 million IDPs. So this is just to give you a scope of the enormity of the problem we're dealing with if we are focusing on 22% of a population impacted by mental health issues. There are many reasons for these high levels of mental health problems among refugees. Florence, you touched on some of them. If we look at countries of origin, that is prior to flight, prior to refugees having crossed the border to seek asylum, many of them have been victims of human rights abuses and subjected to violence. During their journeys to safety, many have suffered similar and additional hardships, and this has taken a toll on their mental health and well-being. Now, on arrival in countries of asylum, many of them are in the most marginalized parts of these countries, accommodated along the borders, in the border regions. And at the same time, the insecurity and anxiety experienced by refugees can have damaging physical, social, and psychosocial consequences affecting their mental health, and in the case of refugee children, their development. Life remains difficult for the refugees and asylum seekers who struggle to make ends meet. Many can no longer benefit from the social support of family and friends they would usually have counted on. Changes in daily life and routine, coupled with sudden and abrupt separation from families, friends, and familiar places, can greatly impact on psychosocial well-being. Refugees also have a constant worry and experience distress about how to create a sustainable future for themselves and for their families. For IDPs, even though the experiences of flight vary somewhat, much of this also holds true. Taking all this into consideration, we shouldn't be surprised by the figure of 22% I cited at the beginning. The impact of the COVID pandemic has been, for many of us, unpredictable. It has been multifaceted, exacerbating and compounding an already very challenging situation. The threat of the virus and the associated prevention and mitigation activities, lockdown, movement restrictions, have had major consequences for mental health and psychosocial well-being for refugees and other persons of concern. Many of the refugees who previously coped well are now less able to cope because of the multiple stresses generated by the pandemic and the weak and challenged social support systems. We've noticed that stress levels have increased due to lockdown, movement restriction, crowded living conditions, and threatened opportunities for livelihood and education. And these have resulted in depression, increased numbers of domestic violence incidents, child protection incidents, and in some cases, suicidal attempts. Many of these refugees have had their hopes for a better future crushed by the current situation. We also see clear signs of mounting stress and anxiety among refugees in the region. For example, we see an increased number of refugee phone calls for support to our refugee helplines in Kenya, in Uganda. We also have received worrying reports of desperate negative behavior, such as alcohol and substance abuse, marital conflicts, and suicidal thoughts. Considering the emerging issues and the effects of COVID-19, UNHCR foresees an increased need for mental health and psychosocial support in all our operations globally. Our efforts are presently geared towards responding to those needs by strengthening mental health and psychosocial support in the work we are doing in refugee locations. We see it not as a separate activity, but a thread that runs through every area of our engagement with refugees and displaced populations, something that matters in every aspect of the work that we do. So what we are trying to do is we're trying to integrate mental health within general healthcare by training general health workers in identification and management of mental health conditions. We are trying to view it as a cross-cutting issue. Therefore, we are integrating psychosocial support in education, nutrition, and giving due consideration to existing and emerging mental health issues among refugees in camp management and camp coordination. We're also trying to integrate mental health and psychosocial support in protection work, such as activities for sexual and gender-based violence and child protection activities. Mental health and psychosocial well-being is not only dependent on what specialists do, but also to a large extent based on factors such as community and family support that we can strengthen. In this particular context, where movement is restricted, where we are trying to ensure adequate social distancing, the refugees we see are having challenges in accessing some of the existing programs that we have in the camp. We are trying in as much as possible to address their needs as through existing community structures, for those in the urban areas through remote monitoring using the telephone, WhatsApp, and other social I would say media platforms. But at the same time, we know that many of them are grappling with isolation and, as I said, the fear of the unknown. So I will stop there. Thank you. Hello.
Thank you very much. You have covered a lot of ground there, a lot of ground. And UNICEF is doing, UNHCR is really doing a lot of exemplary work. Thank you very much. And now moving on to IOM. We know that COVID-19 increased the traumatic experience for migrants. They are migrants who became stranded in the countries where they had gone to work. There are very many people who go to, for instance, the Emirates, the Middle East to work there. And because of the loss of work, because of COVID lockdowns, many were forced to return home, and yet they couldn't travel because of the lockdown. And so there have been a lot of economic migrants who are stranded in the Middle East and in other countries. And I believe IOM has helped to return them, as well as the psychological distress and worries about loss of livelihood. They probably went with a contract knowing they were going to work for 1 year or 2 years, and suddenly that contract is cut off and they have to return home. So to Mohammed of IOM, how has the pandemic affected migrant populations in the region, and how has IOM's work changed as a result of the COVID-19?
Good morning, and thank you also to the organizer for this.
Oh, Michaela, sorry.
Yes, I am representing today Mohammed Abdikar.
Yes, I'm very sorry. Yes, it's Michaela.
Yes, representing Mohammed Abdikar, Regional Director of IOM in the Eastern Horn of Africa. Unfortunately, due to an unforeseen last-minute commitment this morning, he could not be present. He's bringing his regards. As you mentioned, IOM is an agency which is dealing with a very fragile beneficiaries. And it is mentioned that migrants and those living in displacement setting are most likely to be exposed to the condition of COVID spread because of the living condition, working situation, especially lack of access to sanitation and a poor living condition, overcrowding setting. We all know this. But this group, in most of the cases, it has also pre-existing comorbidity, like respiratory tract infection, including tuberculosis, chronic illness. So the pandemic has really brought, for IOM, an untold challenge for those vulnerable migrants, but in the same time for government, handling this health emergency and having also to respond to an emergency within the emergency in this vulnerable group. For instance, the COVID health preventive measures, which were necessary to control the spread, like the closure of border, lockdown, have led thousands of migrants in our region being stranded during the way they were moving without appropriate accommodation, food, healthcare access, of course, and in the meantime, without the possibility to return home. So this has been one of the biggest challenges also by the time we were responding to the epidemic. But migrants were also being at greater risk of being returned to their own countries against their will. We have seen thousands of migrants return back, and in many cases experimented also detention, abuse, and stigma, xenophobia, being blamed also for the spread of the disease. This has led to serious medical health issues, including psychosocial stress in our beneficiaries. It is the first time, I think we all agree, that the mental health and psychosocial issue has been widely recognized as a strong component during a health response due to the heavy impact of COVID, psychosocial impact on mental health. So we hope that as in all the crises, there is also opportunity. So this is the opportunity to expand and to advocate to an integrated mental health and psychosocial program in also during our health emergency. And COVID has given us the path. A big challenge has been for us how also to design our response in a way that it can be sustained and it can be also integrated in national plan and response. We have therefore tried to integrate all our operation tools and SOP we have developed in national responses. And this is, we really hope it will continue even after COVID. Given the nature of the pandemic, definitely our experience has been that COVID has brought at the surface what we already know, and that displaced migrants are most likely neglected in the health responses and plan, including mental health and psychosocial plans. But exclusion for national health program of this population made also early detection, contact tracing, testing, diagnosis extremely critical and sometimes even difficult and impossible. So this is an important message that I would like to address today, especially linking with the current dialogue on the universal health coverage. There is the need to consider the progressive inclusion of migrants, returning and other vulnerable mobile population in the universal health coverage. There is the fact that no one is safe, we know, unless all are safe. There is another point that I would like to address today, that the fear to be detained for migrants had impacted the psychosocial well-being. But in addition, pushed them underground with difficulties to be reached for testing and contact. This is my second message today, that we need to reconsider strongly alternatives to detention, and also not to subject migrants to conditions that can even further expose them to risk of contracting the virus. As IOM, we have joined other members of the UN network, including all the agencies presented today, to call for a suspension of forced return during COVID. And this was also due to reduce the spread of the virus and the burden on country of origin in terms of quarantine, testing, and care. Another challenge I would like to share with you today is the efforts that we had made to continue essential life-saving operation. IOM is a humanitarian and development agency, but in this region, humanitarian response is one of the core areas. So at the early beginning, we made a massive investment or readjust the preparedness response plan, SOP guidance. Also, we activated surveillance mechanism to monitor the number of cases among our beneficiaries. And this has allowed us to learn how to timely introduce also mental health and psychosocial issues. We have learned on the way the impact. So we hope that the lesson learned, especially on continuity of essential life-saving service, it will include more extended mental health and psychosocial operation. The COVID basically impacted, the impact in this population of COVID, in summary, has increased the demand also of humanitarian operation. And it has exacerbated the existing vulnerability. I would say on the positive side, I think also our colleague from UNHCR, Clementine, the regional director, can agree that on a positive side, we have managed to maintain and to contain in our region to only few cases. We shall acknowledge the good work of the humanitarian agency. However, there is not room for compliance, and we need to keep doing what we have done so far. Let me flag something a bit specific to COVID and dealing with cross-border health. And this is the focus on frontline border at point of entry. Their work has changed enormously. And despite the closure of borders for travelers, frontline borders officials had been exposed to an extremely tense and stressful situation to assure the cargo and essential services were maintained for all of us. This has been a new entry point, and also jointly with Unicef, thank you for your great support in this. We have developed a specific tailored training for frontline workers. But this is a lesson learned. And we hope that the mental health, the psychosocial issue will be timely and integrated in the point of entry core capacity in accordance to the international health regulation. There is the need to expand. Basically, what we have changed, many things, I think, like many of our colleagues. Something I want to focus is that because of the COVID, we had to suspend our resettlement program and our assistant voluntary return. And this has been a double impact and has left thousands in our region, migrants stranded. This is another message that I would like to address today, that those type of operations need to be maintained, even during global emergency of this kind. Of course, with appropriate infection prevention and control measures. So we hope it's a lesson learned for if it's going to happen a second time. We also have activated new services. I'm sure you are aware of the assistance we have done for the medvac, so assisting UN staff to travel, and we have readjusted our laboratory to provide COVID tests to our beneficiaries, but also to the UN staff. So basically, in all this effort, what we have seen the impact on the psychosocial well-being of our staff and on our beneficiaries because of the tension around COVID as well. So we have expanded substantially our program on mental health. And in all countries in this region, we cover 10 countries in Eastern Horn of Africa, we have activated MHPSS program, including Sudan, Somalia, Burundi, Djibouti, Ethiopia, and Kenya. Let me quickly refer some of the activities which we really think to be good practice to be continued even after COVID. In Kenya, for instance, the IOM counselor had been providing counseling, remote counseling to stranded migrants. And we have activated the telecounseling. This is a new approach and method. We found that was very efficient and we really hope to continue to roll it out. In South Sudan, we have activated free hotline to reach a remote area. And in Burundi, we have provided psychosocial first aid, even during flooding, because as you see in the last months, our countries, they have been impacted also from natural disaster like flooding, exasperating also psychosocial impact as well. We have developed and continue to engage in training with psychosocial skills. Listening center. This is what we have activated in many countries, and this is for our beneficiaries. And we found that it was possible also to provide assistance, even if it's remotely and online. So those experiences, I think, and we hope to continue to expand. We have learned basically even more during COVID, the critical importance to support also our staff and our beneficiaries. So all these efforts to prevent and mitigate the escalation of mental health and psychosocial issues it should continue after COVID. I want to close by acknowledging also the UN interagency collaboration and partnership that has been going through this COVID response. And this is a way forward, I really think, for all of us. All crisis comes with opportunities. And our opportunity for COVID is also to better expand the mental health and psychosocial and continue for advocating for the integration and the inclusion of mental health in our program. Thank you so much for meeting today. This is over from my side.
Thank you very much, Michela, for providing up good examples of practices in the region, strengthening the importance of having integrated approaches, and also learning, sharing about hope and resilience. We also know that unfortunately, as we were facing COVID, the response to COVID-19, some countries in the region also had to support and face other conflict and armed violence situations. So I'd like to ask Patrick from ICRC, how has COVID-19 changed the work of ICRC, if at all, and if you could also provide some successes and challenges of ICRC's work in East and Southern region. Thank you.
Thank you, Ms. Diop. Good morning again to everyone. Before answering this, or attempting to answer this question, I just want to reiterate my my admiration to speaking on this very important question, and really thank the organizers for bringing this very pertinent subject matter to the fore. A subject matter that we rarely talk about, I would say, publicly, and while touching each and every one of us very deeply. So thank you again. I would say first and foremost that the pandemic challenged us and is still challenging us quite a lot, as you said it very clearly, Ms. Diop, as fighting wars, but also armed violence and intercommunal fighting has not stopped at all on many fronts, especially in the eastern part of Africa, eastern part and southern part of Africa, and where humanitarian needs continue to increase. The equation is, I would say, vibrantly clear. When we say more needs, we say more suffering, which equates with further challenges to social cohesion. Social cohesion that could bring people and communities to a far better place. But unfortunately, because of this fighting and because of this armed violence, social cohesion is unfortunately being not only disrupted, but destroyed. I would say our teams, as well as the Red Cross and Red Crescent volunteers, frontliners of this pandemic, are still and considerably increasing our work, our humanitarian actions. Again, we can't be indifferent to such a worldwide pandemic, but indeed we had to continue carrying family news to the front lines, supporting health facilities in the most remote areas, as well as bring much needed assistance to places where physical distancing was just impossible, like prisons or internally displaced camps. And that work has indeed continued very much. And I would say we can be certainly proud of the continuity of services, namely in the MHVSS realm, but can't but highlight the difficulty to cope with, again, physical distancing with some of the people we work with or the communities we try to serve. And as you know, COVID-19 exacerbates the invisible wounds of war. And we see these hidden wounds of war in nearly all areas of our work, from detention facilities, places of detention, people who have endured ill treatment or torture, to survivors of sexual violence, for example, or families of missing people, people who lost a limb in war, or those forced to flee, like what just Michela brought to the fore, and where indeed communities and countries are unfortunately kept for their own. But I again reiterate that despite the challenges created by COVID-19, we are not only committed to making health and psychological support more widely available in Africa, but we really strive to work, especially in communities affected by conflict or violence. And indeed, we have been adapting our mental health work wherever possible to ensure that care continues, even in the worst of times, even in the pandemic, and support those who really need it. Like, for example, the mental health support hotlines, which are still open, up and running in Burundi, in Kenya. Again, thanks to our colleagues, the frontliners, I would say, and the movement of the Red Cross and Red Crescent, but also a lot of partners very active on the ground. And I would like to conclude maybe the point that Michela mentioned. We also have a responsibility to care for the frontline workers and first responders in the COVID-19 pandemic, including ourselves, including our own staff. ICRC conducted, in fact, a survey in 7 countries, and we found that mental health is perceived as more negatively influenced by the pandemic than physical health. 73% of people surveyed said that they believed that mental health needs of frontline workers have increased. In South Africa, for example, was on the high end, with 82% reporting that they believed frontline workers' needs have increased and really require more support. So in sum, indeed, we had to adapt our work. We had to shift sometimes the attention, but we haven't forgotten the north. We haven't forgotten the direction that is pushing us to do more. In fact, in the absence of any ceasefires or any halt or peace processes that bring indeed the people at the center of our response. Ms. Diop, back to you. Thank you.
Thank you very much, Patrick, and for sharing again all the the scope of experience that ICRC comes across, be it working with the communities or with people in prisons, and last but not least, also highlighting the mental health issues that our colleagues at the frontline face. So thank you very much for all the points you shared with us. You highlighted 2 points on the work with the community and the frontline workers, as I just said. We also have colleagues from REPC, Patrick from REPC. As you said at the beginning, your organization is based in 13 countries in the region, including in some countries which are maybe not traditionally considered as humanitarian settings, but who had now to really speed up and fast track the interventions to respond to COVID-19. So did you notice any impact again of COVID-19 on the provision of MHPSS services to communities, and what can you share in that respect, especially when access has been more difficult? Over to you.
Thank you, Marie. And this is an excellent opportunity to share some of the work we're doing as REPC. With the lockdown, there were multiple impacts at different levels. Firstly, all of a sudden, communities and families who we primarily work with a lot were cut off from essential services. Communities, individuals that depend on REPC to support them, meet their emotional needs, couldn't access this type of support. Survivors of violence couldn't be supported with psychosocial care. Children who are survivors and victims of abuse and exploitation. But we also found that, like you rightly mentioned, as an organization trying to adjust our program approach to this pandemic, we faced difficulties of access. Firstly, our services are essentially given through direct contact with those in need of the services. We try to innovate using SMS for individuals, using radio and other media for awareness raising. But we work in a context where telecommunications infrastructure is very weak. If you take an example of Zimbabwe, Zimbabwe had been already affected by the cyclone Idai, and a lot of the infrastructure had been decimated. And so here we are trying to rely and see whatever else we can use to pass on the message. We haven't been entirely successful navigating through some of the poor infrastructure. Countries such as Mozambique, which is facing, a part of Mozambique is facing a lot of civil unrest. We have families who are in immense need of these services for trauma support, depression and abuse. And we really need to see how to reach out to them. So we've tried to innovate largely using radio, using social media, and also using the phone. The other impacts have been both negative and probably positive impacts and opportunities that we've tried to use, to exploit, to do a lot more. We've seen an increased appreciation of mental health work among the policymakers, but also among the service users. People are beginning to recognize, and families are beginning to identify with the symptoms and the difficulties children and family members are going through, and trying to reach out. We would like to see if we can begin working through call centers, for example, telephone call centers, for example, in Zimbabwe, where people can phone in and get counseling support over the phone, if the infrastructure allows. At family level, we have also seen, in the beginning, as you probably know, there was a lot of discord within families. There was a lot of tensions, children not going to school. The household system was highly stretched. But as we moved into the different phases of the lockdown, we actually began seeing families bonding, mothers spending a lot more time with their children, fathers staying home a lot more. And we're trying to exploit these emerging relations within families to build on those strengths within families. The start was very difficult for every family, but the coping, we see improvements in coping as families become more resilient as well. The increased demand for mental health services comes with its own challenges. The demand is there, but we really need to figure out how to on the other hand, increase the service delivery systems through trainings, like somebody mentioned, reaching out to general healthcare workers, and identifying community systems that are existing within communities that can reach out to families more than care workers can do so. Thank you.
Thank you very much, Patrick. You touched upon things that actually came up in the WHO COVID and mental health rapid assessment, the travel restrictions and how they disrupted access to services. And I think one important thing you say is, while we have an increased demand for services, on the other side, we are hampered by the inability to provide services. This also came through quite strongly, especially for the African region, where as a result of the limited funding that is given to mental health, which was also mentioned earlier, we have a big challenge in providing the services that we know are increasingly need and being demanded. Moving on though, and still touching on services and mental health and COVID, we are now moving to IMC. David has waited very patiently. We know that mental health and psychosocial support for survivors of conflict and disasters is also at the core of IMC interventions, supporting continuity of care and helping communities recovering and becoming more resilient. Can you tell us how the pandemic has affected service delivery to those with pre-existing conditions? And in the setting where you work, what challenges have you experienced in ensuring the continuity of services for people with lived experience of mental health, and how have you adapted? David.
Thank you. It's such a pleasure to be here. We faced a lot of these same challenges, but we didn't stop our services. We had to adapt to these challenges. There were disruptions. There were disruptions in access, but the services continued. And so the challenge was, how do we find a set of client patient-based approach that will enable people with the pre-existing conditions to continue to receive treatment as possible. The disruptions that we had to overcome were just, again, related to the lockdown, that people could not access the services, or that health workers could not access them. And so that has the challenge that people had a daily routine, face-to-face, a friendly face to see every day, access to their medications, having that routine as part of their that may help to maintain their mental health. That was a disruption that we needed to overcome. But what we had, happily, is that in Ethiopia, in South Sudan, and in Somalia, we have a very strong cadre of well-trained workers who could adapt. So we had a great community network of volunteers. We had paid mental health specialists who were on the ground. They were well-trained. They were confident enough to be able to adapt in a lot of the same ways that have been mentioned by my colleagues at IOM, Red C, ICRC, having teletherapy interventions, toll-free hotlines, increased messaging. So with the challenge of social distancing, having group sessions or group messaging is difficult. And so, for example, in the refugee camps in Ethiopia, or the protection of civilian sites, the POC sites in Juba, we adapted by using loudspeaker announcements or having high visibility messages on the sides of vehicles. Always trying to share information about service availability, how it could still be accessed, or how it was being adapted, information about positive coping strategies, and most importantly, having it be in a format that was accessible, that was understandable, that was relatable. By being able to overcome these things, we were still able to work in the local sites, and we also were able to share our experiences at the IASC level. So sharing our expertise and our experiences to develop new guidelines for continuity of services under COVID. And I think that's, we've all experienced the challenge of lockdown, of social distancing. Anybody who's lived with a teenager during lockdown knows what I'm talking about. So being able to share our expertise and our experiences at a global level, I think we all share the benefit of that this pandemic isn't over, and we can still apply these experiences going forward as we're looking at a potential second wave. We'd be happy to continue to contribute and share those materials going forward. Thank you.
Thank you very much, David. Florence?
I forgot to unmute. Thank you very much, David.
Will you take the question to Papa Diouf? Or shall I go? Yeah.
Go ahead, go ahead.
Okay, perfect. So thanks again to David, also for highlighting how IMC is contributing to sharing expertise at that global level and contributing to the standard through IASC. I'll now proceed with a question to Papa Diouf from VSO. It's been highlighted throughout the different interventions how support to frontline workers is key and should really remain at the core of our interventions on MHPSS, and that we need to continuously find ways to support those who have sometimes even the only ones who can access the population when the access has been altered and due to confinement and lockdown. So, Papa, how has your organization acted to safeguard the mental health and well-being of those workers and volunteers involved in the COVID-19 response? Over.
Thank you very much, Mary, and good morning, everyone. So it's always a pleasure to be the last one to speak, because there is such a breadth of knowledge coming out of the discussion. But I think for me, it highlights the need for a multi-sectoral approach to addressing mental health issues, as well as a more coordinated approach. But I really would like to thank you, first of all, the MHPSS working group for organizing this session and this round of event this week to celebrate the mental health, the World Mental Health Day. I think as Mohammed from Unicef mentioned, there was no better time than this year to really highlight this issue that has been there for quite a while. So I work for VSO, Voluntary Service Overseas, for those who don't know. So we are an international organization working in 24 countries across Africa and Asia, and 10 countries roughly in East and Southern Africa. We have a vision of a fair world for everyone. And within that, we intend to fight injustice and inequality through the power of volunteering. So volunteering is at the heart of our programming, and really looking at the relational approach with what we call our primary actors, or the communities we work with, in order to share our knowledge and skills to help them find the solution to the issues. So we focus mostly on vulnerable and marginalized groups. So that would include people with disabilities, that will include, like my other colleagues, prisons, inmates, women and girls, and really trying to be as in line as possible with the Leave No One Behind agenda. So as an organization, knowing that we're working with frontliners and volunteers, mental health and well-being is at the center, has always been at the center of our programming, and really being part of duty of care, because we strongly believe that those working for and with us we should really make sure that they are fully safeguarded, so that they can better support our communities as well, especially given that relational approach I mentioned. So as highlighted by my fellow panelists, COVID-19 has definitely taken a toll to all of us, or to each of us. And I think Patrick was mentioning it. I mean, we shouldn't forget our frontliners. I think sometimes we focus on the communities, which is great, but our frontliners are quite important. The staff and the volunteers are also important, because as we say in French, charité bien ordonnée commence par soi-même. So we need really to think about our staff to make sure that they have they are in the right mental health and well-being situation to be able to support others. So when when the pandemic started, I mean, what really happened is it wasn't new to us. So we built on what has been happening in our organization, and really trying to see to what extent we can better live our organizational culture around duty of care. So one of the things that we've always done, and we've intensified with COVID-19, was really looking at an employee assistance program, for example, which would be offering counseling support to the staff and the volunteers. And that's quite critical, really knowing that you have that support that you can really rely on in these difficult times. So the other thing is really trying to organize also some psychological resilience training, and this is really trying to make our staff, resilient to the issue that they are facing. We try peer-to-peer support as well through small group. We tried also group and individual sessions facilitated by specialized therapists, and we try to raise awareness on mental health issues, but also giving advice to staff and volunteers on how they would overcome or how they would face such kind of issues. And most importantly is destigmatizing a mental health issue as a result of COVID-19, because I think that was quite a big issue that we faced. So the second aspect was more around the programming. But around the programming, really looking at how we can adapt our programming. I think most of the organizations here have had to adapt their programming in order to mitigate the impact of the mental health and well-being of the frontliners. So working with volunteers, some of the things that we've done is really recruiting volunteers who have background in mental health, psychiatric, for example. We're providing that support to the volunteers and really to the communities as well through capacity building, so training, online training, and I think some of you mentioning online training, but most importantly, the community outreach, because I think most of the issues that we face with COVID-19, I mean, the impact of the mental health was mainly due to the fear, and most of the time was because of miscommunication or misinterpretation of the communication, what it is, what should I do, what do we mean by social distancing, etc. So there was a need to demystify, in a sense, and really to sensitize the community to give them the right information, and really to build also the resilience cycle. So the way we did it, like others as well, is using radio programs, peer-to-peer support. In the prisons settings, we've also bring the inmates together so that they have an opportunity to have counseling support. So that has proven really to be successful. But in the midst of all of that, as I was saying at the beginning, partnership was absolutely fundamental, so that we don't duplicate efforts as well. So a good example is in Ethiopia, where with UNICEF and OCHA, we've started a program pre-COVID actually to build the mental health and psychosocial support for teachers in conflict affected areas. And the whole idea here was really to support the delivery of those services for the internally displaced children. But through that process, or through that program, we've been able to approach parents and communities and religious chiefs, and we try to increase the awareness and knowledge of the issue. But when COVID-19 came, it aggravated the situation. So the need to reach those vulnerable children was, due to the closure of school, was even more important. So one of the things we've done is through, I said, the Taylor Radio program and working through community volunteers and youth volunteers, was really to support the communities to understand the issues and really to be able to face those the arising mental health issue, the mental health issue as a result of COVID-19. So I think that there is so many actions that have been done, but as I said, it's quite important to look at it from a multi-stakeholder approach, but a multi-sector approach. I mean, in VSO, we don't have a standalone mental health program. What we try to do is really to embed it, to be integral to all the programming that we deliver. Thank you very much.
Thank you so much, Papa Diouf, again for your intervention. You've completed what the other regional directors have said, but also brought other perspectives on the way you also work with the most vulnerable and disabled people, and sharing some experience in Ethiopia now. So we only have 15 minutes to go, and we'll do our best to finish on time. Thank you again for sharing such a wide experience. The second part of the conversation is related to strengthening investment to strengthen access. And as we know, there's some statistic I'd like to show before giving the floor to Florence for the next question. We know that there's less than 2% of health budgets dedicated to mental health in low and middle income countries. And although we also know that 1 in 4 people will be affected by mental health disorder at some stage. Half of the mental health conditions start by 14 years old, although we know that even in utero, people can also be affected by the stress of their parents, and it has an impact on the development of children. So some costs again about the fact that for every $1 invested in scaled up treatment for depression and anxiety, there's a return of $4 in improved health and productivity. But also to share that international donors spend less than $130 million per year on global mental health. So with that in mind, and again, very few data on the importance of investing in mental health well enough to ultimately reduce the burden, if I may say, on the health fees that the governments have to invest on mental health. I will now give the floor to Florence for a last question to the panelists. Thank you.
Thank you very much, Marie. Just like to note, we are now 95 participants, which is really excellent. I also wanted to recognize the participation of Peter Ventervogel, who's the Global Senior Mental Health Expert at UNHCR. Thank you, Peter, for responding to that question in relation to refugees in the chat. So please, if anybody else has questions, put them in the chat because there are very many people there and some others may be able to respond or ourselves we may respond. We have had quite a lot today about the disruption of services and the increasing demand for services, and yet also knowing that even previous to COVID, we in Africa were not investing enough. The actual figure for the African countries is actually about 10 cents per capita invested in mental health, 10 US cents. This is from the WHO Atlas, the last one. We are now filling another one to see whether we have improved on the investments we are making. But taking that into account, I'd like to ask each of the panelists just one question. We will not ask you two, which I'll ask you only one question. Taking this question, this idea into mind that we do need to be investing more, but also recognizing from all that you all have said here today about working across different sectors, responding to mental health is a multi-sectoral, we need a multi-sectoral approach. The COVID-19 pandemic brought out the need for a stronger way of working across sectors. We are all recognizing that it has come out today. What recommendations could be given to governments to make this happen? So I heard it from almost each and every one of you about working across sectors, working across your different programming areas. Unfortunately, we didn't have a government representative here, but that does not mean you do not work with governments as your counterparts. So I'd like to ask each of you just to give a short example, if you can give one, of any concrete example that you could share of how you have worked across your agencies, but also across government sectors. Thank you very much. We shall take, is anybody who wants to go first, or should we? Who would like, shall we go from the bottom? We start with Papa Diop, backwards from how we started.
Perfect. Thanks very much, Florence. As a good West African, I'm going to turn around before I answer directly to your question. So I think, as you mentioned, from the latest WHO report, I mean, actually only 1% of the health budget goes to mental services. So what we've seen as VSO is that, I mean, those 1% actually go to payment of staff or drug procurement. It doesn't really necessarily go to all the services. But what we realize is, as many of us mentioned, mental health is rooted under stigma around and into discrimination, human rights abuse, grounded into culture and tradition. So those mental services are sometimes there, they're known, but because of the stigma, they are not being used. I mean, for us, what is really important, and given our voluntary model, is really how can we focus more on community mental health services? Because we're not focusing much on that aspect, and that's where we see the work of our volunteers, and I think ICRC and others have mentioned it. That's where we see the work of our frontline workers, and really working with the government to really push that, because the government knows that they need to invest, but I think we need to sensitize them into the magnitude of the issue and how we should be focusing on that. And I think for us, the focus on community mental health services is absolutely critical, because it has been neglected. It is still neglected, and that's where we see the biggest the biggest issue really. I can carry on, but I think that we're running out of time. But that would be, yes, that would be my perspective really on that. Thanks.
Thank you very much, Papa Diop. David, you're next.
Be cost effective. Work through existing structures. Integrate mental health into primary health care or community services. And doing that also provides a non-stigmatizing way to provide the services. You're not going to a separate service provider. It's part of the multi-sectoral or the healthcare services that are already available. And train frontline workers in psychosocial services, make it part of their healthcare with MHGAP or psychosocial training. Use the resources that you have already in the government system.
Okay, thank you very much. Patrick Repsi, yeah, next.
Thank you, Florence. As REPSI, we do quite a lot of policy advocacy work, but we also work at community level. I see generally most times we tend to place the responsibility for planning and budgeting for mental health services on the ministry, on the health ministries. I would propose looking at it more broadly, working with the education ministries, working with the social service workforce, the community, the people, the government departments that do community development work. If each of these other departments understood the need, the how to budget and what to include in their sector plans, I think we'll begin seeing a much broader and holistic approach to this investment we are talking about. There is also what we see is even in education, it is easy to measure education outcomes. But when you do integrating psychosocial within the education sector, we need to look at those measurements and cost them and see what exactly, if you have an education specialist going to plan for these services, what unit cost should they be looking into? But lastly, the social service workforce is a key actor. Somebody mentioned working at community level. If you're working at community level, we need to invest in the social service workforce to be able to understand the symptoms and identify people presenting with mental illness. Thank you.
Thank you very much, Patrick. Patrick, ICRC.
Great. I think David mentioned most of the points that I wanted to make, really, from a multi-sectorial interventions to building local capacities, bringing MHPSS to primary healthcare level, but also working with ministries of health to integrate psychologists and MHPSS care at primary care level, primary healthcare level, as we're doing, for example, in Burundi, in order to ensure a sustainable response. There is a point that I made earlier on the frontline workers that we really need to value. We really need to start from that point, value their work, and then ensure their protection. That's extremely essential. And I think focusing on early interventions would really mean that we build a peaceful transition, or a transition to a peaceful setting, while acknowledging the importance of psychological support of MHPSS and considering as an integral part of our multi-sectorial response, and not as an add-on, but rather as an integrated approach, and have it really as the main ingredient of our recipe. Thank you.
Thank you very much, Michaela, IOM.
For IOM, we have a dedicated service area with MHPSS. So we have always given much relevance in our programming. But in the last years, we have also made efforts to integrate MHPSS in other even non-health service area for IOM. For instance, I was mentioning the focus on point of entry and border officials, and intervention on MHPSS are done in collaboration with our border management service area. So this is one of the strategies look at internally. Externally, I think we are in the moment that we need to strengthen efforts to change the narrative and perception around MHPSS, which currently is considered as a second line priority in public health, due also to competitive priorities. So my message is also maybe joining efforts, strengthen advocacy to change this narrative around MHPSS. And COVID has given us the evidence to do this.
Thank you very much, Michaela. Clementine.
Thank you very much.
UNHCR.
Yes, no, thank you very much, Florence. I think much has been said already, and I fully align myself with the previous speakers, but perhaps let me just touch on a few things. I think, discussions such as these, of course, highlight the scope of the problem and the multifaceted nature of the problem. And I think this is a very important first step. I think I mentioned earlier that in terms of refugees and displaced populations, UNHCR, and we work in partnership, as I said, with many of the people who've intervened, we try to look at it in an integrated manner. We try to ensure that each and every intervention we make, whether it's in the area of health, whether it's the area of camp coordination, education, there are mental health considerations. That way we can use the limited resources that we do have and maximize them as much as possible. I think it's also important to make sure that mental health needs are properly mapped. Allowing caregivers, health authorities, and donor agencies the ability to plan ahead and to act more effectively. When we speak about the lack of investment, I think mapping this out will ensure that we can target investments appropriately. And just to perhaps say that in UNHCR, one of the things that we are pushing, the agenda we have in this particular region, is to try and ensure greater inclusion of refugees in social service delivery, and to try and, as much as possible, have the needs of refugees incorporated in the needs of the host populations. That means working closely with line ministries, health, education, social affairs, and so on. And in so doing, we also try to mobilize additional resources that will not only allow the very limited humanitarian resources that we have and that are very limited in time, but more importantly, allow us to access development resources as well. And we are making a stronger case with some of the international financial institutions that mental health needs of refugees and the populations that host them should be given its proper place, should be prioritized, because it impacts greatly on their ability to access all the other areas of support that we are focusing on. If they're not mentally stable, their mental needs are not addressed, then their ability to access education, livelihoods is seriously impacted. So this holistic approach, I think, will help us use the limited resources that are available as we continue to lobby and advocate for additional resources for this very important sector. I'll stop there. Thank you.
Thank you very much, Clementine. And finally, and not least, Mohammed of Unicef.
Thank you so much, Florence. I think it's Papa Jufu was saying earlier that there is nothing better than speaking last when you are in a panel of colleagues and partners who know so much on the topic that is being discussed. Just wanted maybe to conclude in two messages related to our engagement with government at country and at regional level. The first one is that we have seen it, and I think beyond the legal obligation, beyond the moral obligation to act now on mental health, I think it's also a smart policy choice, given not only the high return that was mentioned from $1 to $5, but given also the way you address the long-lasting and the longer-term impact of it. Knowing that if you don't address it today, it will carry the rest of life cycle, it will be impacting the rest of society development. And I think that messaging has to come across very strongly. The second is that if there is anything we have learned through this pandemic and through this crisis in terms of public policy choice, it is that a single or a sector-focused intervention cannot address the challenge that we are facing today. Something that have started a few months back as a public health crisis have now evolved as a children crisis, have evolved as a mental health crisis, has evolved as a socio-economic crisis, has evolved as refugees crisis, you name it. I think that comes to the point that, looking at vertical intervention or looking at single sector driven intervention wouldn't help us in a kind of crisis like the one we are facing. We need to engage in a multi-sectoral basis. We need to look at the broader picture. We need to look at the ramification, and we need to look at all the lever that we need to action if you want to address mental health. And it ranges from the education sector to the social service sector, to nutrition sector, to health sectors. And I think that's the kind of understanding and learning we got from this crisis, which we need to use when we advocate or when we engage with government moving forward. And I think even if we want to build a strong system, whether it is in education, health, social services, this broadened approach, these broad views in terms of intersectoral, in terms of cross-sectoral, need to be one of the ground on which we will be engaging with government. We will help government engaging into public policy choice or public policy implementation. Over to you.
Thank you very much. Over to you, Marie.
Thank you very much for, you can't imagine how this is important to you also, your staff and people working on these areas, because we'll use, some of the statements you've made today in the following conversations we'll have this week with the donors, with the governments. I believe that will inform the way we're going to work on MHPSS in the region. And that will also be used as a reference in the conversations we'll have with staff on mental health and counseling over the next days. So I think you've covered the wider spectrum of MHPSS as a core element, a main ingredient, as Patrick said, of our protection interventions. We spoke about the community-based intervention, the need to address stigma, to strengthen the capacity buildings of frontline workers, staff and volunteers, the need to strengthen the inclusion of refugees and migrants in our work in the system with the government, and having integrated approaches, and ultimately to join our forces for joint advocacy and fundraising. So, dear regional directors, once again, thank you very much for your interventions today, for your support, and we'll keep you updated as we go this week. You'll see a number of tweets and interventions on social media, and there will also be an outcome report. It's a great interagency approach that we are supporting from all our agencies in Eastern and Southern Africa. I wish you a very good day, and looking forward to being in touch again on this topic. Thank you.
Thank you so much.
Thank you. Thank you so much.
Thank you very much. Bye-bye.
Bye. Bye.
Bye-bye.